Sometimes when people have tried a lot of medications, they start to lose hope. And I think for some conditions and some treatment options, that is the case. The probability of getting better after you've tried a bunch of medications with another medication is pretty low. But the good news about TMS, and particularly the navigated and accelerated options like HOPE or SAINT, is that it seems to be able to punch through even when you've tried a bunch of medications. So treatment resistance is an important question, but it's not the final word. So I had a patient that reached out to me. This patient was a middle-aged man who had tried one medication and it didn't work, and then another medication, and then several medications, all the while in talk therapy, which was helpful, but didn't solve the depression problem. The patient actually made his way to electroconvulsive therapy. That worked, but it didn't stick, and he was starting to have cognitive problems. So even a patient where the electroconvulsive therapy wasn't working well enough called us and said, "Can you help? Can you deliver this treatment?" And he got better. It was an effective treatment for his depression, even when ECT wasn't able to hold him in remission. So even in these hard cases, even in these complex cases, this works. With our most advanced treatments, we're going to take a brain scan and use that to figure out what part of the brain is going to be optimal for delivering your treatment. When combined with our diagnostic assessment, our clinical opinion, we can bring those two things together and give you the best results. Typically with TMS, you will get a diagnostic interview, but that information is not connected to the brain at all. At Acacia, we'll take a special kind of brain scan called an fMRI that looks at the blood flow patterns, and with that 3D video of the blood flow, we're able to see the connections. And that, when combined with the diagnostic interview, lets us have the best insights and the best targets that give us the best results. Recently had a patient come to me with severe treatment-resistant OCD. And OCD is one of the most difficult conditions to treat across the board. We did one of our most advanced treatments, HOPE TMS. We did the whole brain mapping, we did the fMRI, we delivered the treatment at a high dose. And unfortunately, he didn't get better. But we had a clinical trial using a new medication, D-cycloserine, that was able to make the brain more flexible. We used that same neuronavigated target, and then we delivered the treatment using this new medication, and we were able to get a remission that's now lasted for 3 months. The reason I like that story is because it demonstrates just how fast the science is moving and how fast we're implementing it. The use of this medication in this area is very new, and being able to have a clinical trial that we were able to enroll him in, and using that new target combined with this new drug was the thing that he needed. And as one of the first people in the world to receive that particular combination, which was the game changer for him. So we're hopeful that both that particular combination, but also the strategy of continuing to bring the latest technologies to bear is the way we should be doing psychiatry and the way we do psychiatry. The best evidence for neuronavigated TMS comes from studies where people placed a tape measure target, but they also did a brain scan in advance, and they measured how close was the tape measure target to the ideal target. And what they found was the closer you get to the ideal target, the better the result. And this actually explained a large amount of who got better and who didn't get better. It's almost an ideal study. The ideal study is in progress and may even be published when you're watching this, which is randomizing people to a tape measure target against a navigated target. And that is going to be the most definitive evidence, and hopefully will be out soon. After people receive TMS, we encourage them and often facilitate psychotherapy. There seems to be this window right after TMS where people are able to engage in talk therapy or psychotherapy to a remarkable degree. Some patients say that it's almost as if their brain is connected again. Some people say that this therapy in this window is more effective than therapy they've done for years back. It really is this magical time. And so we really encourage people to do therapy, and we think that really helps with long-term durability, keeping the treatment working. We follow patients after their treatment, and for some patients, there's no retreatment necessary. This really is effectively a cure. For other patients, the depression comes back. They do need retreatments, but the good news is that we walk with them through that. We find a way to come up with a schedule or a retreatment strategy that brings people out. The good news is that even if you do need retreatment, it almost always works. We can almost always get people better once we've got them better the first time. We're working in ways to make that more efficient and to keep people better for longer. But the good news is once we get you out, we can usually keep you out. Don't lose hope. You've suffered for a long time, and we don't want you to suffer any longer. But the first step is to reach out. Give us a call and let us know where you're at, what's been going on, and we'll let you know what the options are.